Drugs Decode. In today's case study, we'll discuss the management of hypertension in a patient with diabetes. Pause this video, read and understand this case scenario, and find the clinical issue. We have a 72-year-old female who presents to the emergency department with chest pain lasting 30 minutes, accompanied by nausea and sweating. Her vital signs are stable, with a blood pressure of 135/85 mmHg and heart rate of 78 bpm. An ECG shows ST depressions in leads 2, 3, and a VF, with elevated troponin levels, confirming the diagnosis of non-ST elevation myocardial infarction and NSTEMI. Now, let's discuss the clinical issue at hand. Troponin elevation with ECG changes confirms myocardial injury, requiring rapid management. NSTEMI is a high-risk condition that requires urgent medical intervention to prevent further myocardial damage. Unlike STEMI, there is no complete coronary artery occlusion, but the risk of progression to a major cardiac event is still high. Key concerns in this patient: elderly patient, higher risk of complications from both the disease and medications, already on aspirin. But does she need dual antiplatelet therapy? Renal function, must adjust anticoagulation dose carefully. Now that we've identified the key issues, let's move on to the management plan. Step 1. Acute management. MONA-B protocol. The first step in NSTEMI management is the MONA-B approach. Morphine, for pain relief if severe. Oxygen, only if SpO2 less than 90%, not required in this case. Nitroglycerin, sublingual or IV to relieve chest pain. Aspirin, loading dose of 300 mg, then 75 mg daily. Beta blocker, metoprolol 25 mg twice a day, reduces myocardial oxygen demand. Step 2. Dual antiplatelet therapy. Since the patient has confirmed NSTEMI, we must add a second antiplatelet agent. Clopidogrel 300 mg, loading dose, then 75 mg daily. Or ticagrelor 180 mg, loading dose, then 90 mg twice a day, preferred unless bleeding risk is high. Step 3. Anticoagulation. We also need an anticoagulant to prevent clot formation. Enoxaparin 1 mg per kilogram SC twice a day, low molecular weight heparin. Or fondaparinux if high bleeding risk. Step 4. Statin therapy. Since this patient has an LDL of 130 mg per deciliter, she needs a high-intensity statin to prevent future cardiovascular events. Atorvastatin 40 to 80 mg OD. Step 5. Risk stratification and follow-up. Now, we need to decide on further management. If high risk, persistent chest pain, hemodynamic instability, urgent coronary angiography. If stable, consider non-invasive stress testing before deciding on intervention. Pause this video, read and understand this case scenario, and find the clinical issue. We have a 58-year-old male with a history of type 2 diabetes mellitus and hypertension. He is currently taking metformin 1,000 mg for diabetes, amlodipine 10 mg for hypertension. However, his blood pressure remains 152/92 mmHg, which is above the target of less than 140/90 mmHg recommended for diabetic patients. What should we do next? Before we decide on a treatment plan, let's consider a few key points. Diabetes increases the risk of cardiovascular disease, so controlling blood pressure is essential. Some antihypertensive provide additional benefits beyond BP control, like protecting the kidneys. This patient's kidney function is normal, meaning we can safely prescribe medications that impact the renin-angiotensin system. The first-line treatment for hypertension in diabetics is ACE inhibitors, like enalapril, lisinopril, or ARBs, like losartan, telmisartan, because they reduce kidney damage, diabetic nephropathy, lower cardiovascular risk, effectively control blood pressure. So, in this case, we should add an ARB, such as losartan 50 mg once daily, and continue amlodipine. Now that we've adjusted the therapy, what should we monitor? Blood pressure weekly to assess response. Serum potassium and creatinine to check kidney function after starting ARB. Lifestyle modifications, including salt restriction and weight management, to further support BP control. With this approach, we expect better blood pressure control, slower progression of diabetic kidney disease, reduced cardiovascular complications. And that's how we optimize hypertension management in a diabetic patient. Thank you. We will continue this case discussion as series. I will see you in next interesting case discussion. If you found this case useful, make sure to like, share, and subscribe to Drugs Decode for more clinical case discussions.